All right, so let's continue into the hospital-acquired pneumonias. So these are going to be something that happen as a result of being in. So when we look at hospital-acquired pneumonia, or HAP or HAPs, these occur when the patient's been at the hospital 48 hours or more after admission. Typically, we have gram-negative organisms. So which gram stain color is negative? That's right, pink. Pink is negative. So usually when we have patients that get a hospital-acquired pneumonia that's more than 7 days, we're looking at Pseudomonas or MRSA or E. coli. So all of these that are not typically going to respond to your typical, they're not going to respond to your typical penicillins. So now, when we look at this, there's a difference between hospital-acquired pneumonia and healthcare-associated pneumonia. So there's a it's a fine line, but there is a difference. These are patients that are hospitalized in an acute care facility within 90 days of getting an infection. So let's say that you come in for a tonsillectomy. And within 90 days, if you get an infection, that is classified as a healthcare associated pneumonia or an HCAP. So these are things that we definitely want to make sure that we stray away from in the healthcare community. But we see this mostly happening in our LTACs, our nursing homes, the PAMS facilities, those long-term cares. That's when we're looking, those are the areas that we would typically see this. Usually they're on some antimicrobial therapy or some chemotherapy. They're getting wound care within 30 days of pneumonia. So are getting a pneumonia within 30 days of getting those therapies, it would also be classified as a healthcare associated pneumonia or an HCAP. So when we look at hospital metrics, some of the hospital metrics are to keep your HCAP scores down. And so these are a couple of things that we want to just make sure that we're doing so that the patient is doing everything that they possibly can to not come back to the hospital and see us. We don't mind seeing you at the grocery store, but we don't want you to come back to the hospital and be a patient. The ventilator-associated pneumonia. So about 25 years ago, there was a big campaign, and the Institute for Healthcare Improvement and its partners put together this campaign to encourage hospitals and other healthcare providers to take the following steps to reduce harm and deaths. So this is an institution for healthcare improvement, and what they're doing is they're trying to make sure that if you came in for a right foot amputation from gangrene, they wanted to make sure that you didn't have the left foot amputated. They wanted to make sure that central lines, the infection rate with central lines were down, that the infection rate with surgical incisions, those sites, those surgical sites, that the infection rates were down there, and also preventing ventilator-associated pneumonia. But this is the leading cause of morbidity and mortality in the intensive care. It's the second most common cause of hospital-acquired infection, and it costs upwards of 50 million, probably even more so now. That might be an old statistic, but $50 million are in healthcare dollars are spent towards towards ventilator-associated pneumonia. So it's definitely something that we need to do, something we need to do as respiratory therapists, because who is responsible? The entire team is responsible ultimately, but who is caring for that patient the most? And I would say respiratory therapists are at the bedside of these ventilated patients, and we need to make sure that we are doing everything that we possibly can to prevent ventilator-associated pneumonias. So one of the things that can cause ventilator-associated pneumonia is when you have a difficult intubation and you're utilizing multiple ET tubes and you have an esophageal intubation and you use that exact same tube to intubate the trachea. So anytime that there's an esophageal intubation, you get a brand new tube. You do not wait to say, this one's clean enough and wipe it off on with sterile gauze that is at the bedside. No, you get a brand new endotracheal tube when you have an esophageal intubation, because that will be an increased risk for ventilator-associated pneumonia. So when we look at the ventilator bundle, these are RT initiatives to help prevent ventilator-associated pneumonia. The number one thing that you can do, and this is 100% preventable, hand hygiene. Are you foaming in? Are you foaming out? Are you washing? Doing a full wash at the beginning of your shift after you have gone to lunch. Maybe you've stepped outside for some reason, but make sure we are washing our hands. Wash your hands to make sure that you are taking care of preventing any sort of bacteria getting to your patient through lack of hand hygiene. Now, this is more of a local practice. This is not national expectation, but you want to make sure that you're getting a sputum culture. Now, a patient may come in with not necessarily any signs or symptoms of a pneumonia, but a lot of hospital practices are to get a sputum culture as soon as that patient's intubated. You typically have, depending on your facility, less than 4 hours to get a sputum culture from a patient that's been intubated. So a lot of facilities are going to get a sputum culture immediately after intubation, and it's to identify if that patient ends up with an infection later. Was it something that we caused? Was it hospital acquired, or was it community acquired? So that's what that is for. Now, not every hospital does that. It is not even part of the full-blown expectation when it comes to the national standards. But if you have a patient that has or is intubated because they are in respiratory failure secondary to a left upper lobe lobar pneumonia, the second with Klebsiella pneumonia, absolutely get that sputum culture. You want to make sure that you are maintaining an adequate cuff pressure. Now, some hospitals have you check that Q shift. Other hospitals have you check that every 4 hours. Now there's even technology that it's out there that will monitor and maintain an adequate cuff pressure continuously. So if you don't have a cuffometer or a cuffometer, you can use the minimal occlusion volume unless there's some contraindication that says you cannot. The other thing is we want to make sure that the head of the bed for our intubated patients is greater than 30 degrees. Now, 30 degrees is the bare minimum. So these patients should be at 30, 35, 40, 45 degrees. In some parts of the country, we have patients that can sit upright at a 90-degree angle if you have the verticalization bed. And if we can get these patients out of bed, that's even better than them laying in bed, because earlier we talked about it. It's a risk factor. It's a risk factor if you are in bed for prolonged periods of time. We want to do oral care. Sometimes that's Q4. Sometimes that's Q2. There's not a specific practice as to how often it is. And typically this is a shared responsibility between nursing and respiratory. Just make sure that you guys are in sync with who's doing oral care and when. Other things that we want to do is we want to use 72-hour suction catheters. Way back when, we had suction catheters that we could not use for multiple days. They were a daily suction catheter, and we had to exchange those out every day. Well, guess what happens when you break the circuit what we found is every time that you break the circuit, you increase the risk for ventilator-associated pneumonia. So we want to do everything that we possibly can to prevent that from actually happening. And we don't want any routine vent circuit changes unless the circuit itself is visibly soiled or it's inoperable. So at one point, I remember early in my career, we had a routine. It was actually a scheduled thing that would come up on our tasks. Every 7 days, we would change out the vent circuit, and every 14 days, we would change out the ventilator itself. But we've kind of strayed away from that practice because we've identified that there's an increased risk of pneumonia by doing so. Aspiration pneumonia. All right, here we go. Now, when we talk about aspiration, this is not like I'm aspiring to do great in life. This is actually somebody that has inhaled, whether it's saliva or some other foreign body that leads to an infection. So this is, by definition, an entry of material from the stomach or upper respiratory tract into the lower airways. This is the the major cause of anaerobic lung infections. This is often missed because it's an inflammatory reaction may not begin until several hours later. So you have to recognize, did you observe that aspiration? And a lot of times when there is an aspiration pneumonia, it can actually progress into acute respiratory distress syndrome. And we know that ARDS has a very high mortality rate. So we want to make sure that we're doing everything that we possibly can to prevent aspiration. That's why it's so important to check those cuff pressures, because there are microaspirates that go through those microfolds from the upper airway that migrate down into the lower airway, and they can cause these anaerobic lung infections. So maintaining that cuff pressure, I'm going to get on my soapbox. Maintaining that cuff pressure is something that we need to do more often than never. We should be doing this at a minimum of every shift. If you do it more often, fantastic. And if you have the equipment and the means to monitor your cuff pressure continuously, I highly encourage you to do that. So, all right, I'm off my soapbox. But other irritants that can get into the lower respiratory tract is the gastric content. This is actually toxic to the lungs. Your gastric content is very acidic, and it can cause damage to your lower airways. Any sort of obstruction, whether it's a foreign body or a fluid like saliva, kiddos are at risk for foreign body aspiration. It's not only, secluded to pediatric or kiddos. We had, and one time in my career, we had an adult who was dipping, and they were stunned by something, and that dip went into their upper airway, and they ended up aspirating that dip. So crazy. It can happen to adults as well. That progression of inflammation, typically, like I said, it's several hours, but the time frame is about 12 to 26 hours. And there's 3 different types of aspiration. It's toxic injury to the lungs, whether that, like we said, was the gastric content, some sort of obstruction of the foreign body, or an infection in itself. So GERD, GERD, gastroesophageal reflux disease. So this is regurgitation of stomach contents into the esophagus. So patients that have acid reflux, that is your gastric contents getting up into the esophagus, and it's so acidic. Look, your gastric content is your gastric fluid has a pH of 7.25 or less. This can cause a serious pneumonia, and it can be fatal. So patients that are on proton pump inhibitors or antacids, that they are at risk for these toxic injuries. pH of 1 to 1.5 can cause parenchymal damage, inflammation, edema, and even hemorrhaging of the airways. So, what GI condition might put patients at higher risk for aspiration pneumonia? I gave you the answer earlier. That's GERD, and the reoccurrence of GERD, if aforementioned GI condition may cause this secondary pulmonary condition as aspiration pneumonia. Dysphagia. So dysphagia is abnormal swallow that can involve the oral, the pharyngeal, and the esophageal phases. So it's got a number of different points at which dysphagia can be impacted. So a lot of patients that have had a stroke, so patients that have had a CVA or a cerebral vascular accident or a hemorrhage are going to be at risk for dysphagia and an abnormal swallow, which would put them at risk for aspiration pneumonia as well. So those are your patient populations that are more at risk. There's what's called silent aspiration. This is where the patient does not actually have a cough or a choke or a gag. It does not invoke clinical observable adverse symptoms is kind of the technicality of that, but they do not have any sort of coughing, choking, or immediate respiratory distress. So that is what we call silent aspiration. When we talk about those stroke patients, they are a increased risk. Tracheostomy tube patients or tracheostomy patients have a 55 to 70% chance of aspirating. So lots of potentials when it comes to aspiration. So who do you think might be on the interdisciplinary team that could help us out with these patients that have dysphagia? Yeah, you want to look at your speech pathologists. You want to look at your dietitians. You want to look at your occupational and physical therapists and your nurses as well. And those aren't in any particular order. Those are just talking about patients that might be at risk for dysphagia and put them at higher risk for aspiration pneumonia. Those are the folks that you want to collaborate with to make sure that you have all of the right elements taken care of, so that the risk for aspiration is decreased. Other diagnostic tests that will increase the risk of aspiration pneumonia is going to be a modified barium swallow, fluoroscopy, endoscopy, and Evans blue dye test. Those are all different diagnostic tests that can increase the risk of aspiration pneumonia. And then you have patients with chronic pneumonia. We talked about this with patients with CF, but these are typically going to have localized lesions without regional lymph nodes, regional lymph node involvement. They're going to have granuloma, inflammation. These are tiny clusters of white blood cells and other tissues that start to show up. Typically, are patients with CF, HIV, tuberculosis. They are more at risk for chronic pneumonia.